said, Sue knew much more about this than I did. So okay. Okay.
All right, so if everyone's ready, we'll kickstart. So Susan Becker is here representing DuPage, and though she's not intimately working with the Breakthrough Care Center, Sue Walsh, who is working there, was not able to make the meeting, so she missed out on the opportunity to network with everyone, see San Francisco on a dinner cruise. But Susan's here to give us the overview and the great stories.
Yeah. So I am actually really excited to talk to you guys about this today because it really is a innovative and exciting project that we're doing. And we have 2 centers, and you just walk in and you can feel just a total difference than walking into a normal ambulatory care clinic. It's pretty exciting. So one of the things we wanted to do was we wanted to figure out how we could deal with those, that top 15% of patients who are using all the healthcare dollars and have an effect on those patients. I mean, I know everybody's seen this slide, but we really wanted to identify those patients and be able to treat those patients. So what we came up with is our Breakthrough Care Center, a totally new model of caring for these patients. We're dealing with those patients who have comorbidities and are the sickest of the sick. The goals were to identify those sickest patients, to provide holistic, coordinated care, and to utilize the EMR to monitor the health status and the outcomes for those patients. So having that really as one of the goals, I think everybody was a little nervous because we have been putting data into the medical record for many years and not really sure how to get that data back out. And the data that we were getting out, we weren't really confident of what it was going to tell us or that we were getting accurate data. So the first thing we needed to do was identify those patients. And we used 4 different types of models, risks, whatever. We looked at 4 different things. First thing we did was looked at our clinical risk factors. So we did some data mining within the EMR to find those high-risk patients. And then one of our physicians, Dr. Krause, who is actually one of the primary care physicians at one of the clinics, also sits on one of the boards at our local hospital and reviews all the ER visits, whether they get sent home or whether they're admitted, to identify whether it was appropriate for those patients to go in. So he came up with a list of 130 factors to identify those patients, and then they weighted them. They also used the Johns Hopkins telephone assessment tool to make phone calls, and this tool looks at patients' social and mental risk factors for disease. And then they looked at, we did some more data mining, looked at our ER utilization and our hospital utilization, so identifying patients who were frequent flyers. And then, of course, we used the Charlson score to identify. And then another way we get patients is, of course, through our primary care physicians' referrals and hospitalists. Because sometimes you just might not, the data might not show you a patient who is obviously in need of help. The staffing model is a little different. We have 1 MD per clinic. We have a clinical manager. Sometimes it's a nurse, both in these instances are nurses. We did toy with the idea of having a non-nurse manager. It came back to the nurse or an LPN at least. We have an APN, and we're looking to expand that to 2 APMs per clinic. We have health coaches, which was new for DuPage Medical Group, receptionists, therapists on site, a physical therapist at the clinics. We can do x-rays and labs, and each clinic has its own social worker. The health coaches went through extensive training. They followed cardiac, they went to visit our cardiac center, renal, geriatrics, pulmonary. They learned about social services, services within the area. They learned about age and dementia, motivation. They went through motivational training for interviewing. And then they spent at least a week learning about chronic care. So they went through a lot of training. And our Health coaches right now are both, all 4 that we have hired are all APN or LPNs. We can do home monitoring through Numera, which downloads right into Epic. So we get blood glucose, weights, BPs, and these recordings are then uploaded into the EMR and are sent through an in-basket message to the physician and the nurses, so they can monitor while the patient's at home how they're doing. And we get real-time reporting through Reporting Workbench, and those of you that have Epic, if you haven't implemented Reporting Workbench, I highly recommend it. It is a great tool. And what it does is it's basically a registry, and you can flag certain patients, and it'll bring up real-time reports on that patient. So you can tweak it however you want. If you want to look at asthma action plans, like here, they're looking at weights, last visit, last encounter, blood pressures, all that kind of stuff. So it gives you real time. And so the nurses look at this every day, and the health coaches look at this to see who they need to follow up on. And then based on what they're finding, especially through if they're doing home monitoring, they can call that patient, have that patient come in that day. So I've got 3 patient stories, one here, and I think this one was presented at AMGA, because I've heard some people talking about a 6-hour visit last night at dinner, and it was a patient that Dr. Krause saw. The patient came in with a hemoglobin A1C of 16.9, and that is a true, it's not a typo, that is a true hemoglobin A1C. The staff worked with him for over 6 hours. They were able to give insulin right there at the clinic, and constantly monitoring the labs because we have a lab right there. The patient ended up going home. The pharmacist called the patient the next day and was monitoring their blood sugars at home. And the patient also had an abscess on his neck, which general surgery came by and excised that while he was there. Without being able to do that, that patient would have spent at least 6 hours in the emergency room and then 3 to 4 days in the hospital before being able to go home. One of the things, a couple other stories that I have that this story doesn't get to, what we're finding is that the most important thing is having that social worker on site. Every patient is seen by the social worker, and every patient that we have had in these clinics has needed something. There was one patient who was going to be having to have his foot amputation from out of control insulin or diabetes and not being able to afford his insulin. So they had planned the surgery, and just in talking to the social worker, the plan was, of course, for this patient after he had his foot amputated to go to rehab. That's standard of care, right? Well, his copay for the rehab unit was $50 a day. He could not afford $50 a day for a copay. So what the clinic did is they brought his family in. They taught him how to do transfers in physical therapy, which was a one-time copay of $50. And then there's a gym right next to the physical therapy, so they transferred him out. He could come in as often as he wanted to the gym, practice the transfers. They had a family conference where they organized the home care. They got all the equipment that he needed at home, went through all the medications that he needed. The gentleman had his surgery on Friday and went home on Saturday. And all because of the social worker finding out that the gentleman could not afford his copays. And just a lot of psychosocial issues that we're finding. So there's also a pharmacist on site. So it's a really amazing thing. If you have any questions, Sue Walsh, I would actually have you give her a direct call, because she is the one who actually was the project manager for this project and put it all together. It's amazing. So I can try and answer your questions. I do know a bit about it, but if there's any questions, yes?
What's the ratio of how many patients in that one doc?
Any given day, probably about 6 to 7. It varies because they do get patients in, but right now each clinic, we have a total of 150 patients within our organization in the clinics, so there's about 75 at each, and they're geographically located. DuPage County is very big, so one's kind of on the southwest side and one's more on the north or east side of DuPage County. So, and we're finding one clinic is much busier than the other, the Northeast. That's an older communities are there, whereas the Southwest is much younger, newer population. So it's not exactly equal. We have about 150 patients already. So, and our doctors are doing home visits too. If a patient can't get in, they're going out to see them. So, yes. Oh, sure. Sorry. Any other questions? Thank you.
I've met some of you, but not all. Hello, I'm Paige Nelson. I've met some of you, but not all. I feel pretty fortunate to be here this trip because in talking to many of you, what I found out is that you really have moved forward in terms of medical homes and have pulled things together. And so Becky and I have talked and are really happy that we're here. I represent the Everett Clinic. I'm the Director for Quality Improvement there, and nurse by background. Our organization has about 450 providers, a few over 350 docs, multi-specialty group. We're located in Snohomish County in Washington, about 30 miles north of Seattle in Everett. And we have imaging labs, 2 ASCs, and let's see, we have a partnership with the oncology team in the hospital. We are not an integrated system, which is makes it very interesting for us. But about 75% of our patients are admitted to our local hospital, which is part of the Providence system in Washington and Oregon. What else can I tell you? We're physician-led and physician-owned, and that's a very important feature compared to a Kaiser. So we're much more like a Centera and organization in terms of how we do our work and how we do our initiatives, and we are driven by being able to tell our senior exec team that we have a return on investment for whatever initiatives that we put on the table. And we work very collaboratively with them back and forth to be able to define and implement those initiatives. So I wrote a few notes down here. I'm going to refer to those. We see about, I think our patient base is about 300,000. And we started in 2008. We had an opportunity with one of the largest employers in our region to actually have what they identified as an intensive outpatient care program. And so they identified 3 groups who were high performing in the area, and we worked with those other groups, collaborated, got data, and started care plans for a list of, in each of our institutions, a list of patients that were identified as high cost. And so we started, we like to, as the person who runs this care management program says, we like to dabble, and we like to pilot things and trial different things. We're very good at that. We're not always so good at following through on things, but we're very good at dabbling. And so this was one of those things where the reward was great enough that we certainly did continue with the care management program. We were able to demonstrate, I believe the last number I heard, a 20% cost savings for these groups of patients across the board for the 3 groups. So that project went on for several years, and we have continued to establish similar goals related to this. The organization goals overall are about providing better care for the patients, improving the clinical outcomes, and also decreasing cost. Becky and I are involved in a major initiative that was initially named Reducing Cost of Care in 3 years by 25%, and that started a couple years ago. And so we are now calling that, as we are changing our contracting, we're actually calling that value-based our group is called Adding Value. So we wanted to twist it around a little bit. But the contracts that our administrator is working on are basically value-based contracts, and we have shared savings and risk in those contracts. So I'm very fortunate to work with this group of docs and the teams that we work with. Let's see. So the things that we've implemented as we fast forward to 2013 is we now, whereas we wouldn't have conceived of this before, is we've put into our services standardized programs for disease management, case management, and utilization management for our health plan partners. We've actually realized that we have a much better chance in our scenario if we actually manage those specific programs versus having the health plans manage those programs. So we've had to, in that way, as you all have are certified through Medical Home, we achieve our certification and through those programs with health plans because it offers us a business opportunity. The things we've implemented, we now have nurse care managers that are embedded at our 9 sites. We only typically have one. Depends on the size. Our sites vary from approximately 7 or 8 to about 30 docs. We have one more that we developed recently that has about 45 docs, I think, at least. No, maybe it's a little bit less than that. But anyway, most of our sites range between about 8 physicians and ACPs and 30. We've also put in place transitions of care nursing at the hospital. So you can imagine that since we don't own the hospital, we have to work pretty hard on the relationships with the hospital. So we have them sit on our care coordination committee. We've developed a program where when the hospital has an admission through ER and the physician who's seeing the patient doesn't think that he needs to really admit the patient, they give us a call and we make sure that patient has an appointment next day with their PCP. So that's one of the programs that we put in place. Another program is our hospitalist will go ahead and try to update primary care physicians when there are particular patients who are particularly complex because there are hospitalists. We have about 40 to 45 hospitalists at the local hospital. We also are experimenting with a new physician model in which, because we do have worked by RVUs, we have changed this physician salary to physician's pay to a salary base, and the patients are seen on, for complex visits, and this physician has much more support than the rest of our physicians. I'm sure many of you are experimenting with this model in your own sites. So different payment model, different bonus situation or expectations in terms of what they're doing for a bonus situation. Let's see. We do have an EPIC system, full disclosure. We have had registries since the late 90s, and we have reporting that is remarkable. It's updated daily, and it's live data for our docs, for our staff. They use reports for the visits that are for both pre-visit and bring the patients in, and the reports identify the needs for that day or what you all identify as opportunities. So we've had, because of our strong IT support, which does come at a cost, we've had the ability from the quality department to push change and improvement. We've been transparent with our data with physicians for many, many years. Our CMO, Dr. Fisk, talks about us being transparent with our data on our website so that, for example, you might have your physician satisfaction data. He said, how could you better improve their scores other than putting it out there for the public to see? And as you know, that will happen in 2014 regardless, so why not start sooner? So what else are we doing? We have a palliative care program that we designed and have worked with community support to be able to make sure that it is effective. We have, let's see, we did, as part of our quality measures for last year, I know other people have talked about that after, the 7-day period when you want to contact your patients after they've been discharged, what we had was our clinical frontline staff do that. We provided them with the data of the patients who were discharged at that point in time, but we also had a measure on the quality targets that was about doing that specifically. So we went around as a quality team, we worked to educate and bring those 9 sites along so that they understand what the goal is. So we try to align the work from the quality department alongside the work of both the frontline and the other teams, whether it's what IT is doing or it's what the care coordination team is doing. We're all united, or what it's with what coding is doing. So working on the RAF scores and making sure that we're all in tandem and trying to learn together how to get this done. We do have social workers. They are not embedded, but we find them very significant and important. Let's see. Dashboards are part of our huddles, so we'll have information. We use a lean system, so we typically, as some of you described, have huddles on a regular basis during the day in terms of how things are going at a leadership huddle, and then at the staff tier 4 levels. We also have individual results displayed, how many health maintenance and disease management items were taken care of for the patient population the day before, and our focus on patient population, we decided to narrow it down for a while, is on that Medicare population. So we are specifically working on the Medicare population. We were losing a lot of money and knew we needed to improve on that. I think Becky, anything else you can think of? For us, it's really a lot about relationships with our community. Another piece, we do have an end-of-life group. What fun, huh? But we put that in the quality department so that it would be interpreted appropriately. We have a physician champion for that. We know that that's something that's going to be incredibly important, and we know that most of the cost of care is during those last days, so why wouldn't you want to make sure the patient was informed in advance? It's right now, we're working with some videos. We have a plan. This is on our targeted measures for the fall in terms of education and training of our providers, although some, because of our physician champion, are already on board with that. I'm sorry it's not more in depth. If you have questions, I'd be happy to try to answer them. All of this is not my content. It is really about us all working together at the Everett Clinic in terms of Becky's team, my team, which is the quality team, the care management team, and the coding team. And we actually have physician champions who are coders, and a whole group, actually, which doesn't really relate to the intensive outpatient program, except the fact that you want your patients coded appropriately, and it's kind of important. So in summary, that's a little bit about the Everett Clinic and the work that we do. And we get kind of narrow-minded sometimes with our physicians, so we have to kind of encourage them. And we've recently developed a primary care steering committee, which is that advisory group that we talked about, so that we can engage them. Those outlying groups that are all by themselves, how can we bring them on board and make sure that we're trying to decrease that variation in practice instead of kind of setting ourselves up for more of it. So, any questions? All right, well, thank you for your time. Yeah.
What percentage of your revenues are fee-for-service?
So fee-for-service for, you're not talking about Medicare. So fee-for-service, I would say.
Not about anything your company does.
Right, so we have about, I believe, 60% commercial.
60%?
I believe so. Becky, where are you? I'm pretty sure I'm pretty right on that, yeah. So our commercial.
With your return on investment, where's your, I mean, this is wonderful work, but how do you monetize it?
So what we did, so when you think about the shared savings and the risk contracts that we have for our Medicare population, and we went to explain last year when we needed a nurse for disease management, we only have one nurse for that program. And we were in the process of defining that program. So where would be the value in that? the value is that we don't have the health plans doing something that was disconnected with the work that we are doing, and that we are able to provide that advice to the patients ourselves, and to provide that whole sequence of care in a continuum versus having a health plan call them and say, oh, really? And I've worked for a health plan, so, and actually manage case managers there. But you end up being able to provide care that is held within your own organization versus having an external influence that might not be appropriate. So where does that pay off? That pays off over here when you have a contract that makes a difference in terms of whether that patient is coming back for their next visit, whether that patient is engaged, and whether or not the physician is also engaged. We have found in our contracts that that's where we get our payback. So we were able to show an ROI for that particular nurse based on the fact that the contract was going to perform. Does that make sense? I might not have explained it in the same terms. Well, it's actually due to the risk though that we have. It was based on shared savings, which we got at that point. Now it's based on our risk because we have to perform. Yep.
Hi, I'm Dr. Chris Naglia with Holston Medical Group. I'm a hospitalist, and I've been doing this for 10 years with Holston Medical Group. I'd like to give you our version of an extensivist program. I think we probably need to give you a little background on who we are. Holston Medical Group's a multi-specialty, physician-owned and physician-led group. We have a group of hospitalists. It's predominantly primary care physicians. We have an EHR that is separate from the hospital systems in our area. We have no formal affiliation with the hospital systems in our area. We're in Appalachia, which is East Tennessee, Southwest Virginia. A lot of people refer to it as the Bible Belt. If Dr. Jaffe were here right now, I think he'd refer to it as the stroke and heart attack belt. We are in a ACO named Qualiable, and this little bubble map at the bottom shows patient density of populations of who we're caring for. The larger the circle, the larger the population. So to get started, I'd like to give two quotes to kind of set the tone for what was the catalyst behind our extensivist program. And the first one comes from the book Unaccountable, Dr. Martin Macri. A hospital is no longer the community pillar I knew growing up, with its altruistic mission guiding its decisions. Hospitals have merged and transformed into giant corporations with little accountability. What is the product of this corporation? It is hospitalization. A second quote comes out of New England Journal of Medicine, Harlan Krumholtz. This was just January of this year. Probably a lot of you have already heard about this, post-hospital syndrome. Patients recently hospitalized are not only recovering from the acute illness that put them in the hospital, they are also experiencing a period of generalized risk for a range of adverse health events. So what Dr. Krumholtz was suggesting is just by being in a hospital, you may be contracting this syndrome that puts you at risk for another hospitalization. It's worth taking a look at just the different things that go on in a hospital that can predispose somebody to this. So now that I've thrown my darts at the hospital, which is a fairly easy thing to do, I'm going to direct some of these darts internally and at Holston Medical Group. Right now, our group pushes patients to the hospital too. We direct patients to the hospital. And let me give you an example of how we're doing this, not intentionally, obviously. But this was just a patient last week, Mrs. Mullins. I don't know if she's a relative of yours or not, Kathy, but Mrs. Mullins' daughter came, she's 80 years old. Her daughter came to visit her, lives out of town, saw that her mom wasn't doing so well. Mom had no complaints, but agreed to go to the doctor's office to be checked on. They got a work-in appointment, 2 o'clock in the afternoon. doctor who's seeing her, knows her for 10, 15 years, but his schedule is booked. This is a work-in patient. He's got 10 more patients to see by 5 o'clock. He's already behind as the work-in patient. Mrs. Mullins' heart rate is up a little bit. She's a little tachycardic. Check a UA on her. She does have some bacteria in her urine. The daughter has a lot of questions about mom. The doc doesn't have quite as much time. The 20-minute visit is already 5 minutes overdue. And so what does the doc do? He goes, well, this is kind of complicated. Why don't you go to the ER for further evaluation? So the patient goes on over to the ER. She has an ER physician who's never seen this patient before, who doesn't have access to our electronic health records. And all that ER physician knows is that the primary care physician, who knows Mrs. Mullins for 10, 15 years, thinks she needs to be at the hospital. Well, take it a step further. The ER is getting busy. It's by now 4 or 5 o'clock in the afternoon. People are starting to roll in. The ER physician just had a talk by one of the hospital administrators earlier in the day saying he's keeping patients in the ER too long, got to move them through. The ER doc notes that Mrs. Mullins is a little bit tachycardic, and he calls me, the hospitalist, to admit this patient. And so what started out as a little snowball when the daughter came to visit her mom has now become this huge snowball rolling down this hill at me, wanting to go into the hospital. You recall, Mrs. Mullins never had a complaint. And now here she is, 5 o'clock in the afternoon, or by now, by the time I'm seeing her, 7 o'clock in the afternoon, with a little bit of tachycardia, but no real reason to put her in the hospital. There's a lot of social issues. There's a lot of work that needs to be done on her, mostly on an outpatient basis, setting up physical therapy to evaluate her for fall risks at home, checks on her, maybe nursing, some home health. There are issues, but we've started this cascade of hospitalization. I can try to stand in front of that snowball and brace for it and stop it and push it back up the hill and send her home. And we do that on occasion. But in general, if I'm getting busy too, the daughter thinks her mom needs hospitalization because PCP sent her there and the ER doc is saying that she needs hospitalization. It's very easy to step aside and let that snowball roll right into the hospital. Takes more time, I can tell you from personal experience, to try to set everything up for that patient in the ER and get her home that night. It's much easier to just admit. So that's just one of the ways Holston Medical Group, and I'm assuming many of your other groups, are allowing this habit of hospitalization, just send them there. We also have problems with our phone triage. There's a lab that was drawn earlier in the day. It's a little bit abnormal. It's 4 o'clock in the afternoon. The PCP gets it back, and the patient's already gone home. So call them up, just tell them to go to the hospital. Let them deal with it because it's too late and I can't bring them back now. So these are some of the things that were the catalyst for what we're trying to do. And this is how we came up with this extensivist program, and these are the different arms. It starts with the hospitalist, because a lot of these high-risk, multiple comorbidities, the patients with a proclivity towards hospitalization, as everybody's saying, the sickest is sick, are touched most by the hospitalist. Another arm is our transitional care team. I'll talk about that. Another arm of this is the extensivist clinic. I'll talk about that. But this extensivist program also involves the PCPs within our group, and it involves multidisciplinary rounds and multidisciplinary team action. We have PharmDs. We have Coumadin clinics. We have clinics to help and assistance with these different things. What this slide doesn't have is we have the arms, but there is a net in between all this, which is holding it and protecting this patient. And the net is our IT department. The net is our analytics. Jason Tipton's going to talk to you about that a little later. So our transitional care. I'd like to give you one more story here about the importance of this transitional care. This is the hot topic in hospital medicine now, where the patient is their most vulnerable, leaving that hospital and assimilating back to the community, getting back to the PCP. without breaking down. And so I'd like to talk to you about another patient that I had recently treated. This is Mrs. Dingus. It's another common name in Appalachia. It's unfortunate, but that's a common name. She's also 80, and I admitted her for congestive heart failure. She has poor vision. She's got a 6th grade education. She has balance problems. She lives alone, and none of her children live nearby. Complicate things more, she's on 14 medicines. One of the other problems we have in Southwest Virginia and East Tennessee is we have one of the highest medications per capita of any of the states in the country. So you've got this older lady who can't even see to read her bottles, minimal education, in the hospital with congestive heart failure. I do my job as a hospitalist, get her breathing better, and I'm ready to throw her out. Not my problem anymore once she leaves that hospital door. But it is my problem, because guess what? I did a great job with the congestive heart failure, but she's going to be back in the hospital next week. Why is that? And a lot of this does revolve around the transition of care. Right now, when I put orders in to discharge Mrs. Dingus from the hospital after her congestive heart failure, I'm putting orders in for physical therapy to go out and see this patient, work with her balance at home, check if there's any throw rugs or poor vision that she could trip over. She needs home health to go out to the house. A sister with her 14, probably now 15 or 16 medications I'm sending her home with. Draw some labs. She's on digoxin. She's 80. She needs a digoxin level checked at home. So I type these in the electronic health record at the hospital, have case management, check a dig level, set up PT, set up home health. Well, as this patient leaves the hospital, who's responsible for seeing that those things even get done? And since we've instituted inpatient care coordinators, which are Holston medical groups, I just kind of assume when I put those orders in there, they get done. More times than not, they're not getting done. There's no accountability to that case manager or the hospital to really ensure these things are going to be done. Because just like me as a hospitalist, I'm kind of washing my hands of the patient when they're leaving. Same with the hospital. Now I know that there's penalties coming up with these things, but right now we're seeing things aren't getting done. There's no accountability once that patient leaves the hospital. So what we've done is we have two types of coordinators. We have inpatient care coordinators that are rounding with the physicians, the hospitalists, meeting the sickest of sick patients in the hospital, the ones the physicians are most worried about. They're going in and seeing the patient so the patient and their family can put a face to a name. These care coordinators review medications. We're going to get some farm techs to help them with that, to make sure that that medication list is the same as the primary care's and is updated as the patient leaves in a different medical record once they leave the hospital. They're doing the 48-hour phone calls. And this isn't rocket science. These things that they're catching are so simple and basic that they're game changers. You send somebody home with an antibiotic for their pneumonia, you just assume they're going to take it. You're the doc, you told them to take it, why wouldn't they? Well, I can't tell you how many times we called, or they called the 48 hours or the day after, and they didn't get that antibiotic for their pneumonia simply because they couldn't afford it, or there's all kinds of reasons. So the care coordinators have met the patient in the hospital. They're RNs and LPNs. They've met the patient and the family in the hospital. They're calling them. They're ensuring follow-up with the patient, 7-day appointment like everybody's talking about. They're also checking, did the physical therapy make it out? Do you have a physical therapist coming out? Did that digoxin get drawn by the home health? Are these things happening? Because you'd be surprised how often they are not happening. We also have outpatient care coordinators that don't meet the patient, and they handle the less sick patient. Our inpatient care coordinators right now are covering traditional Medicare and just our sickest of sick who we really feel have the most social and other needs for follow-up. Outpatient care coordinators updating medications, making calls as well. They're just not quite as involved, and it's for patients a little less sick. We also started using Performance Clinical Systems. This is a software packet. It's the iCloud based, and it is helping us close the loop on a lot of this. Because one of the other problems when I discharge a patient is, again, accountability. What's going to happen? There's a blood culture that's out 24 hours, but we're waiting for the 72 hours, and I don't have that. And as a hospitalist, I'm not proud of it, but I don't follow those blood cultures up after the patient's been gone for 48 hours. Once that patient's out of the hospital, it's out of my hands, and that's how it is. Well, Performance Clinical Systems, we first use it in the hospital. We're able to get it off the internet. It is compatible with our electronic health record, but it's also useful, even if you don't have an electronic health record, a paper system, it can help send information and orders back to the PCP. But what I'm able to do with this is order the primary care physician to follow up on those blood cultures in 72 hours. There's a checkbox that I can task the primary care physician. You need to look at these in 48 hours to see if anything grew out. And so it's not being dropped. And that's just so important in keeping up with what's going on with the patient. Performance Clinical also allows us some data collection, lengths of stay in the hospital, but I won't get into that too much. Next arm of our extensivist program is the extensivist clinic. This is more of a vision. It is due to roll out next month. But what we see as our extensivist clinic, which is a little different from some of the extensivist clinics out there right now, the ones out there right now are mostly handling those sickest of sick with the most comorbidities. We're looking to capture the patients that you would traditionally send to the hospital. This extensivist clinic that we're going to start is right next to our urgent care center. It's an infusion center. There's reclining chairs. We have IV access. We're going to have BiPAP access. We're going to have a crack nurse who can get lines in. She's already the infusion nurse, very high comfort level with very sick patients. And the hospitalist will be right there. The goal is to catch these patients that traditionally would get sent to the ER. Not every patient, but diseases we're looking at are CHF, and not just CHF, but an exacerbation of CHF that would normally warrant a hospitalization, a COPD exacerbation that normally that primary care physician seeing that patient in the office would say go to the ER. Pneumonias, dehydration in some of the elderly with an early sepsis. These are the patients we're looking to capture. We're going to have a triage phone. The PCP will call this number and say, hey, I've got this patient talking to the hospitalist in my office. I think they need hospitalization. Can I send them down to your extensivist clinic? The hospitalists who are going to run it have a little higher comfort level with sick patients. But the big thing that we're going to be given is the luxury of time to turn this patient around. There's no 20-minute slot where you have to get Mrs. Mullins better. I have, as long as the clinic is open. We're going to have it open for 12 hours initially, looking to keep it open possibly all night long. Hospitalist right there, looking to turn the patient around with IV fluids if they're dehydrated, IV antibiotics, IV Lasix if they're in heart failure, and BiPAP support if they have a COPD exacerbation, steroids. Well, truly acute care, but outside hospital walls. If I fail in being able to turn that patient around, simply write admission orders, bypassing the ER and directly admitting the patient to the hospital where you'll follow them up in the hospital. If you succeed or the patient reaches a point where they're stable enough, maybe they can go home that evening, sleep in their own bed, get probably better sleep than they would in a hospital. Do that, let them come back the next morning for another 4, 6, 8-hour intervention. The patients we're going to not accept in this clinic initially are if the PCP is calling 911. If they're that sick, they need to be in a hospital. We're not looking to capture every patient into this clinic, just the ones that are not truly hospital admission status, but can't really be handled in the office. We're also not going to handle chest pain secondary to the liability, even if you only have 1 in 100 patients who actually turns out to be a true coronary syndrome. It feels best to be served in the hospital. 3, if the patients, give them the option, do you want to go to this extensivist clinic where we have a widescreen TV, it'll be a quiet room, you'll be comfortable, your family will be there, or do you want to go to the ER in the hospital? They choose the hospital. We're not going to argue with that. The clinic will also serve as a post-hospitalization, so it's kind of a bi-directional clinic. I might be able to discharge a patient a little sooner if I know I can see that patient in the clinic the next day and have a period of time to take care of all the patient's needs. Most of the patients will go back to their PCPs if we feel like they can do a hospital, if that patient's hospital follow-up visit is expected to be reasonable within a half-hour period of time, they're better served by going back to the PCPs. But if there's a lot of work that still needs to be done, the patient can come out of the hospital, follow up in this extensivist clinic the next day for treatments, further things. And so, again, we're looking to roll this out next month. It's not proven yet, but that's kind of what we're looking to do. And that's it. That's my information if you have any questions. Thank you. Any questions?
Staffing, some kind of money. At 12 hours, a hospitalist, what's the capacity you're envisioning in that?
We don't know yet. We have 4 beds or 4 rooms right now. We don't know, but we expect it to take off, because, again, it's not just the patients going in that you're going to be capturing and spending a fair amount of time, but it's going to be follow-ups as the patient is leaving the hospital. So it could get very big, and we just don't know. Yeah, we have basic radiology, basic lab, and we're looking to get blood gases from either the hospital or there's a respiratory company that's within our building to see if they couldn't provide that. So basic labs, no CT, and basic radiology.
And my last question, will you have patients who actually did get sent to the ER and then maybe instead of getting those marginal patients, take them out of the ER and over to the central clinic, or is that going to be too politically broad?
Yeah, I think that might be a little charged, but certainly the day after the ER visit, again, we do have the ability to stand in front of the snowball occasionally and say, and the patients frequently say, I don't want to go into the hospital. I know my PCP said it, and I know the ER doc's saying, but I'd rather go home. So that would be a patient that we would set up in the clinic the very next day after the ER visit to take as much time as we need with them to get social, not just the medical issues, but the social issues, just like the Everett Clinic was talking about. Actually, I guess it was Susan was talking about having social workers on site. There's a lot of social issues that go into this, not just the medical issues. And yeah.
Those hospitals, do you think it'll be just a one-time only visit, or do you anticipate that you see them a few times during those 3 days?
It depends. First, not every discharged patient will go into this clinic. Again, if there's not a lot of issues or needs, they're probably better served by going back to their primary care physician. But if you anticipate a lot of needs and a lot of patient time, they will go to the extensivist clinic. And if they need multiple visits to get them and keep them stable and keep them out of the hospital, it may be several days in a row of this.
We're actually implementing a very similar model. We're surprised that we do so many different life and works. And our concept is that if they need to stay in the extensivist clinic, they'll stay there. If not, we want to get them back to the primary care physician. And we're using it as almost like a consultative service rather than the primary care side of the cultural standpoint, and try to move patients between positions that can lead to some animosity. This is viewed more as a clinical referral to a specialist than a transfer of primary care.
I'm hoping our primary care physicians will really enjoy this and appreciate it. We're not trying to steal patients. We're helping them out of a jam where they don't have to follow up. They can continue seeing their patients, where they don't have to spend 45 minutes, an hour with a patient where they may not have that time. If it's too complicated for their time allotment, send them to us and we'll take care of it, hopefully.
Just a comment. I'm sort of the referee between these cultures, between hospitals and practitioners. I think that they're separate. You've got to realize you have primary care people now that never go to a hospital after the residency. And we've got this staff. They can't handle some of these things. One point that I'd like to make as quickly as possible is this performance clinical system is taking. Last year I mentioned to those of you at the meeting, I want to take care of the Friday night patient discharge on Coumadin and IV antibiotics who's 80 years old and a little bit out there. I can handle that patient. Because of the software now, I know when the hospital team sends somebody home, it goes into my EMR. So anytime anyone transfers it, the second piece that's important here is the patient portal. I haven't cleaned that up yet, but we all want it. The patient portal is the daughter gets home, she says, what medicine is that patient on? I want a live event, open up the portal, don't give it 2 of those bottles and don't say Coumadin.
Thank you.
Excellent. Good afternoon. If I could ask everyone's indulgence, would everybody please stand? Stretch. I know it's been a long afternoon. I see all the smiles through the room. I figured if I had to stand up for a few minutes, I could
Do you want to lead it too? You know, like right arm that way.
Do I have a pointer on this?
That has a pointer and the green thing up there. That's a point.
Okay.
That's a point and click another one.
On this one, even better. Oh, I might keep this one. If you'd like to sit back down, you can. If you want to remain standing, that's fine too. Okay, for the next 5 to 10 minutes, we're going to kind of step back and we're going to look at a pure analytics model on how to break your population down into different specific risk groups. We've had a lot of conversation and questions asked earlier today. We've had some presentations about high risk, frequent flyers, the IP groups. What we're going to talk about is at HMG we basically are trying to work through several models on how we identify patients. Now, as we move through this is our total population. You can see we are 82% commercial, 15% Medicare, Medicare Advantage, 2% Medicaid, 1% self-pay. You can see the question at the top, how do you identify what population is in need? Notice we didn't ask need of what. What I would suggest as a recommendation when you start looking at how you break your population down, you need to have a clear understanding of what you're trying to get out of it. At HMG, what we wanted to do is we wanted to identify groups within our population that we wanted to make sure they were getting the type of care they needed, period. It's not a financial consideration, it is a part of it, but we wanted to make sure we were providing care for our patients. Now, how did we do it? There are lots of ways you can do this. We decided we would start very simple. So what we did is we identified a specific list of conditions that we applied to the entire population. This is the list of those chronic conditions. This also has, we broke down the percentage of prevalence within the population. You can see hypertension, diabetic. How about that? What we wanted to do is identify against the entire population how many, we had to have a specific time frame. We looked at 2 years. We call that a quote-unquote active patient. Patient needs to be alive. That usually helps. You did a distinct count of how many conditions each one of these had per patient. It's a straight count. We didn't do any weighting. We did, if they have hypertension, diabetic, depression, asthma, means they've got 4, period. Now, if you can get to your diagnosis codes and you can query those, you can do this type of analysis. There's a lot fancier, sexier ways now that are available with Humedica. We're going to talk about some, but this is a basic query. This is where we start. Once you've got a count for a patient, you basically apply a logic that makes sense to your organization of how many conditions, what does that mean for the patient? How sick are they? What risk stratification do you want to put in? Clear so far? At HMG, we said, okay, we want to see 3 buckets. We want to see those patients that have no condition, 1 condition. That's our healthy population. 2 to 4, this is our managed care population, those that we want to make sure are getting in to see the PCPs, getting to make sure they're getting all the care that they need. Level 3 are 5 plus. This is the group that we want to make sure we focus on. When we started this conversation, we thought, well, it's easy to identify the level 3. Let's go look at where our high spend's at. What we found out when we dug through this and we started looking at some of these that have 5 plus conditions, a lot of them are the frequent flyers. 30% of this population had a hospitalization in 2012. But there's a large part of this that had 5 plus conditions documented, didn't have a big spend. Weren't what the providers would say, this is one of my sicker patients. But what we did is we sat and we looked and we said, okay, Miss Smith has 6 conditions, hospitalized 3 times in 2012. Mr. Jones has the same conditions. He's 3 years younger. He's on the same track. He has not been hospitalized. We want to draw that correlation to say that's where you're going. To get a predictive analysis out of something so basic. That's the group that we're wanting to look at. That's the group we're wanting to call and we're wanting to make sure that we're touching. Still clear so far before I muddy the water? Did I miss anything, Chris, on the bottom? Let's see. I'll talk about some of this. For our population, we could do an immediate action against the level 3 patients. It's a manual chart audit. We went through with our coordinators and identified gaps, called the patients. It was eye-opening for us to look at some of those that we haven't seen in 6 months, that we're going to call 6 to the sick. It was very eye-opening. As we moved through, we identified level 3s, those that are sick. Manual approach, we can do that. When we looked at level 2s, thousands of patients, that's not a manual chart audit. We don't have the resources to do that. So we needed a better way to try to stratify those patients that are level 1s and 2s that have some serious conditions but may just not have a pure count. So what we did, using Humedica and the Mindshare, they have HCC risk scores that you can rank against your population. Everyone know what an HCC code is? Hierarchical condition categories. Using Humedica, we can go through and basically take our entire population and rank from the sickest to the most healthy. That gives us a quantitative approach to be able to go through and say from a level 2 patient, those that need some managed care, if we need a more focused effort, where do we start? It gives us a much better idea to do that. What we did is we used the initial chronic condition count to establish our baseline. From an operational standpoint, we identified 2% of the population is about all we're capable of putting a focused attack on this group. Can't do more. 18% the managed care, 80% that we dub healthy. This is what we did for HMG for the risk scores. If you do this internal with your own organization, it'll be whatever you want it to be. You can customize the levels within Humedica. The big issue with this for HCC is it's completely dependent on the coding from the providers. Now, what we want to do is we're going to touch base at this conference basically on this topic. We want to come back in the fall. We're going to bring Dr. Hager, he's our coding expert, and we want to be able to show where we started this process in February. When we come back in September, we want to see if there's a trend, if we can see from a coding standpoint, from a population stratification standpoint, how this looks. Okay. So we can put them in buckets. What does that mean? What do we do? This was the very first slide I put up. Again, commercial, Medicare Advantage, Medicaid. You see this is our entire population. Let's look at it from the levels. There's your level 1. You can see 66%, still commercial. You see the Medicare is growing a little bit. There's your Medicaid, self-pay at 3%. Let's look at level 2. Any trend anybody starting to identify? Let's look at our level 3. Okay. So if you only looked at the total population, you only looked at, okay, 82% is a commercial population. If you did no more analysis on your group and your patient panels, that would lead you to believe we really ought to focus a lot of our process and program on the commercial group. When you start talking about what quality of care do we want to give to our sickest patients? Secondary, where's your high spend? As you start talking about a Medicare Share Savings Program, if you're in Medicare Advantage, your gain share programs, if you're going into risk, where your spend's at, where the care's at. That's what we identified with this. This was not necessarily a big surprise when we looked at it, because the question was, who's the sickest group? Where's the spend at? Well, it's your older people. Makes sense. 85% of our sickest of the sick, that was rather surprising. Yes. Yeah. When we did this range, this is our entire population broke out by your payer group. Okay? Okay. So we've talked about how we break the population up into groups. What I want to talk about now is just one of the processes that we've identified that we're actioning today and how we're doing it. There are lots of things we're working on. Dr. Neglia talked about some of the extensivist program. What we want to look at is specifically our Medicare Advantage population and annual wellness. Code GO38, GO439. How many in the room do these? Just a handful? Just a handful? Everyone's so tired you can't raise your arm? Okay. Of those that do an annual wellness visit, how many do you do? Anybody? Do you do a lot of them? Do you do a few? Do you do a handful? Do you do what's convenient? You do a lot. Okay? We historically have not. We work with Allscripts. We have an annual wellness template within Allscripts within the EMR. It's clunky. It's not much fun. It takes 45 minutes to an hour to do. Nobody likes to do it. It's a break in the workflow. So guess what? They didn't do it. What we've done, Dr. Neglia touched on Performance Clinical Systems, PCS. It's a clinical checklist. It's a smart clinical checklist. What we've built, another facet, it's used within the extensivist program out of the hospital to capture data. We also use it for an annual wellness visit. How this is built is it goes through and it says of all the information you need to capture to be able to claim for an annual wellness visit, we tie it back into the EMR to where it uploads the demographics. It uploads the conditions. You don't have to ask the same question 5 different times the way we had to last year. If the patient is not a diabetic and they don't have a diagnosis, guess what? It skips that whole section. It's a much more efficient process. So how it works for us is right now, we're still using the chronic condition count, but we're talking about using Humedica for the HCC coding. So we're identifying a patient list. Who do we want to talk to? Chrissy and I will work in decision support. We'll identify this list, and then we'll get it out to the care coordinators who are going to schedule and talk to the patient, Medicare and Medicare Advantage. They're also going to conduct the first 15 minutes of the annual wellness, 30-minute total. So the first 15 minutes, they're talking to a coordinator, face-to-face, who they talk to on phone, who explain to them what an annual wellness is. It's not an opportunity to get your medications refilled. It's not an opportunity to go through additional issues or pains or aches. I know within the group there's a lot of confusion when patients come in and they think, well, I'm going in to see the doctor, I can go through the whole spiel. The coordinators are explaining up front what this is for. The second half of this, we're using nurse practitioners. You notice there's not a provider within this process. Right now, we've been doing this since February. We're averaging 1.2 follow-ups per patient, where we're identifying gaps in care, we're identifying needs, we're identifying lots of issues where patients are then coming back to see the provider, and it's then within a 20-minute window, 15-minute window, but it's for something specific. To where, because all the providers are busy, they now have a targeted action with the patient. All that's documented in Performance Clinical Systems. As Dr. Gendron said, it's web-based. We do have an interface with our EMR because that helps make the process more efficient. You don't have to do that. That means you just have to type in patient demographics and conditions. It uploads for us into the EHR, which then we can tie back into Humedica, and it starts to cycle over. Like I said, this is just one thing we're doing, but we wanted to touch on this. The good part for us and for groups, it is annually reimbursable. We do get paid for it, so we like that. These codes are also used if you're in Medicare Shared Savings Program or ACO. CMS has a specific group of allocation codes. That's how they allocate lives to your group. These are 2 codes. So the more you see your patients, you get paid for these codes, the better care you can provide, and you also can raise your allocation of lives. It's a no copay, no deductible process for the patient. You get to see them face to face with the level 3 patients. That's really what you have to have. You have to have them in. And let's see. Another part that's near and dear to Chris and I's heart is the data capture. As Dr. Negley had touched on earlier, the template that we've built within PCS captures 22 of the 33 required measures for the ACO. We also ask 7 questions that are tailored to give an indication on the other 7 chat survey questions about what the patient thinks. On a scale of 1 to 10, how do you rate your provider? If they say, well, he's a 2, okay, red flag. We might want to see why they believe their provider's a 2. So basically, we're looking at the 33 ACO measures. We're capturing 29 of them by going through this process. So lots of benefits come from this type of process that we like. These are some of the wonderful smiling faces that each of you. Dr. Gender and I elected not to put yours on here since everyone got to see you live. So, I didn't think Memorex would do justice. So I tried to make this kind of short and sweet. They gave me the toughest slot of the day. After lunch, end of the day, last scheduled presentation. What questions, comments, recommendations? Sure.
What are your demographics? Because you have a fairly low percentage of the Medicare patients, and at the same time, like with this, you are using HCC, which is designed by IDEA to handle elderly population.
Yep.
And it's not surprising that it's picking up with those groups in that level 3, mostly Medicare, because HCC is designed to do that.
Mm-hmm.
Right, so there might be some huge gap in what you're doing.
What you're looking at here is based on the chronic conditions. Now, if you're looking at different age groups and the chronic conditions we chose, now, let me go back to that. These 17, we had built and looked at other queries. This was a group of conditions that we had identified. We had the query built. This was a relatively easy step because everyone had bought into this listing. If you elect to do some type of stratification using chronic codes, these can be anything you want. We tried to do this just as a general coverage for the population for everybody.
We were seeing that coming back from our claims feed. That is who we were seeing the most of on our population. So we chose those as a bucket based on claims.
Right, but then you're stratifying your risk based on the HCC. And you choose.
These are chronic conditions.
Yeah.
Like I said, the HCC codes, you're right. CMS designed them for the Medicare Advantage plans. That's the population they're tailored to. That's really why we want to come back to this group in the fall and answer that question of, okay, here's where we were by doing a pure count of chronic conditions, not weighted. Here's where we see with HCCs, and see if we have a big gap where we're only now seeing it skewed toward the older population. Great question. That's a concern we have. We want to follow up on that.
So your level 3 result came out of your count.
Count, correct.
And have you done any work yet to correlate HCCs to your level 3?
We are starting,
That's what you're doing.
we are starting that process now. We've done some initial queries. The level 3s here, again, this is mostly Medicare and Medicare Advantage matched against the HCC codes. We're probably what, Catherine, we looked at about 60% of a match. So it's not dead on, which really brings the questions of the gaps that could be created. That's kind of why we want to track it for 6 months and see how that correlates.
I think it'll be interesting to see what the match is in the other groups. One thing that Jason just mentioned is that culturally, there's a real drive in this group towards very complete coding, regardless of care class. So I think you may have a better match than you might see in an organization that puts the focus on RAF scores in a particular care group.
Yep. We had a question in the back.
I was just going to clarify that the HCC score is developed and normalized on the Medicare population is actually the community source. Because if you think about the
And that's one of the things we wanted to look at from a coding standpoint. It's a great point. We want to see where this goes. What we wanted to do, though, is to get, kind of step back from looking at a pure cost component to break the groups out. Because like I said, we saw some that we haven't seen that have 5+ chronic conditions that look exactly like someone else that we have been in the hospital 4 times. So that's some of the great benefits we captured. But by no means are we saying this is the perfect way to do it. It's just we wanted to share it. Yes?
Did you crosswalk your results at all with the Charleston measure that they had in Humedica?
We have not. We have not. We went through and discussed the Charleston and really talked about the benefits back and forth. Since, as Catherine said, HCC coding is it is a current process we're trying to improve within HMG. We have a lot of risk contracts with our Medicare Advantage group, so this is going to be very important for us. So instead of doing the Charleston, we said, well, we're already focused on HCCs. Let's look at this through the Humedica MindShare with HCC and see how it correlates as we move forward.
Has anybody, any of the groups done any of that?
Yeah, I have actually. You can do the whole thing and Charleston School and ACC. You know, they roughly correlate, but not precisely as you would imagine. So, you know, I think we'll be using the Charleston School sort of that analysis to identify high target, potentially high target ACC credit competition. So it's an interesting exercise. It's very easy to do.
We have another product that I'm going to check out on Jason on. It's actually heat map. I don't know if you've seen the heat map on the very thing, but we have data going back until 1996, and we found a company that should be able to heat map. So heat map doesn't care whether your doctor's putting the problem or the medicine in the right thing. The heat map looks for, if somebody says no diabetes, but they've got 10 blood sugars over 450, the patient probably shouldn't have been labeled diabetic. So I'm very excited about this other product. So when he comes back next fall and we talk about coding, I'll have something to double check on doing my coding. But no,
They'll just get signed up for next fall.
The company already done it with us. It's very exciting because you can literally go on this map and find patients that are totally mismanaged from an EMR point of view, and maybe mismanaged quality of life, but you find them despite the Medicare data and the rest of it.
Okay. We had a question in the front.
Yeah, can you go back to these slides? To your percentage.
There?
No. Yeah, so right there.
This, okay.
Yeah, so right here, was this, in listening to what Catherine was saying, this was after you had kind of tested your coding accuracy and you were pretty confident in it, or I'm just asking an open-ended question on because this depends on pretty high fidelity coding.
What we did is, as I said, we took the entire population. Christina went through and she built every one of the ICD-9, the diagnosis codes that matched each one of these, queried it against the entire population, and this is the results. This is the prevalence within. These low percentages was a surprise to a lot of the providers. Am I saying that HMG has perfect coding, we've coded everything? No.
And it was more based on if you saw that E&M code in that office, what diagnosis did you charge out for that day? And then counted it that way. So naturally, the stroke, all of those were fairly low, but we caught that in our urgent cares.
And my second question is more for the group. Do you think it makes sense to peel out the pediatric population? Because both from a risk stratification and a workflow point of view, I think that they are handled quite good.
I see some head shaking. I think that was an open-ended question. Anybody have a comment on that, of pulling the peds out?
I don't think it's going to make a big difference, but the peds that do have those conditions should be in that risk scoring, and if they don't, most of them aren't going to have any of those conditions.
Some of the conversation we've had from an ACO perspective is the BMI added into this, which pulls back into the peds. I mean, from an ACO perspective, that's not the population they're looking at, but just an overall care of your population health becomes a big question. So it's
yeah, I would say that, and Richard, I mentioned here where I work, we have a kind of high needs pediatric center, and those tend to be kids with congenital issues, really the asthma, pediatric asthma is a little different from these other chronic diseases. It's a 1X disease. People that have pediatric asthma, they rarely have other serious comorbidities. Whereas with diabetes, you're likely to 3X. You're likely to have 3 other comorbidities. So I'm just wondering if, what do you think about that? Because it's a different type of care coordination, it's a different type of eye utilizer.
Yeah, it's, the other one that the third-party payers, the insurance companies want is behavioral. Behavioral pediatrics is becoming a big one, so you're right. But, we rarely have multiple conditions except for the congenital retinopathy. That's a very, very small group. I don't know how it would affect the numbers. Now, from a pediatric point of view, provided when they look at my adult guys getting bonuses and stuff, you can bet that the pediatricians are saying, how about me? And I'll be honest with you, in the world of asthma and in behavior, there is a definite advantage to decreasing the cost of that. And hypertension is a small amount. I must admit, the teens were not very good about that.
So we love the dialogue back and forth, the Q&A. But we do have a break coming up. I'm running a little bit behind schedule. So want to let everyone get up, grab a break. We got some great snacks, including ice cream out there. So if we're completely melted, and obviously Jason will be on the cruise tonight, so you'll be able to corner him.
Thank you.
Thank you. That was excellent.